So I want to thank the organizing committee for this invitation. Unfortunately, I am on call, and I wasn't able to be there live. So the subject is about the distal biceps tendon ruptures in high-performance athletes using the endobutton. From the epidemiology, the incidence of these ruptures is about 1.2 per 1,000 per year, and 10% of these bicep ruptures are in the distal part. The dominant elbow represents 85%, and men over 40s is about 93%. Some of these ruptures are happening during athletic activity, about 30%, and the cause is the excessive eccentric tension of the tendon. And the smokers have 7.5 times greater risk of rupture. Now, the diagnosis, we can do it with the patient history. Sometimes the patient feels a pop, there's an hematoma and hemosis in the elbow, and the clinical examination, the best test is the hook test, as it's presented here, with your finger. And of course, we can do an MRI that has a sensitivity and specificity of 100%. The treatment can be non-surgical in low-demand patients or medically free patients, or when we have a partial rupture of the tendon. And surgical, the indication is to improve the strength, and the flexion about 30%, and the supination about 40%. And of course, this allows us for early rehabilitation. These are the surgical options: bone tunnels, suture anchors, intraosseous screws, the cortical button, the intramedullary button, button and a screw, and recently some endoscopic techniques. This is the first publication from Bain in 2002. With this technique, the biceps repair we use with the endobutton in about 20 patients with good results. And what are the advantages of the cortical button fixation? So we have, first of all, a superior load to failure strength, and also we have a superior cycle load to failure. You can see here that the endobutton has about 440 newtons of strength, and the suture anchor about 381. It's quite similar. But theoretically, this allows early motion, and there's no need for protective casts for 3-4 weeks, as we do with the anchors. We have in our clinic 22 male patients, 18 acute injuries and 4 chronic, with an average age of 27.5%. The dominant extremity was 19 to about 80%. You can see here the athletic activity that they had. This is a small video with a surgical technique. So we can use, usually I use a simple incision. You can see here that we trim the distal part of the tendon, and then we put a suture in a whip-stitched fashion, like that. And you see the assistant holds the endobutton with the clamp, and we leave about 5 millimeters of distance in order to accommodate to the posterior cortex. Then we measure the tendon, as you can see here, using the instruments for the ACL. Usually it's 8, the diameter. And then we do the drill. This is very important because we have to go a little bit ulnar and distal to avoid the nerve with the arm in full extension. The first drill is the endobutton, 4.5, and the second drill is only the anterior cortex, about 8 millimeters, to accommodate the tendon. And then we pass the button with the sutures, as we do with the ACL. Here. In about 20 degrees of flexion, and then we pull it. Now the tendon is in, and we flip the button as we do with an ACL. So we are sure that the button is in the cortex. And then we can check our repair. And we close the skin. Now, common mistakes are we have to protect the nerves. Usually, we don't use Homo retractors. In the video I used, so this case had a pin palsy. It's the only case that I had. The trajectory of the pin is very important, 90 degrees and slightly ulnary to avoid the posterior derosus nerve. Always do fluoroscopy intraoperatively. You can see here where is the button. It's not my case. Avoid fixation in significant tension, and also we have to thoroughly debride all the wood, because with this way we avoid the heterotopic ossification. These are the results. The mean Mayo elbow score was about 94, and the flexor strength, it was returned about 94%, the supination 90%. I don't use a protective cast. We allow passive ROM for 2 weeks, active range of motion in 4 weeks, and back to sports in 3 to 4 months. I had one pin palsy that has been resolved 7 months later. We can use this technique also for chronic ruptures of distal biceps. This is a case that we use an allograft, Achilles tendon allograft. You can see here that we prepare the tendon and the diameter of 8 or 8.5. This is the button, and this is the Achilles tendon. We flip the button, and then we extend our incision to put all these grafts into the belly of the biceps, like that. This is a systematic review that we have done a couple of years ago about the clinical outcomes and complication of cortical button distal biceps repair. You can see here that we have about 100 patients, 7 articles in the final outcome review. The interesting thing is that the post-operative physiotherapy protocol, it was different. So you can see different authors use cast for 1 week, for 2 weeks, 2 weeks again, or splint, removable splint. So the theoretical advantage of the button is that there is no need to use a cast, but as you can see, the authors use the cast after that, because probably they don't feel safe. And if you see the results, it's a little bit interesting, because still, with this technique, you have a lot of deficits in the range of motion and in the strength, and also a lot of complications, as you can see here. Most common, the lateral antebrachiocutaneous nerve palsy or posterior derosseous nerve palsy, also wound problems and problems with the buttons. So despite this ultimate strength that is proven biomechanically, it seems that most surgeons prefer a short period of immobilization in a cast. So the theoretical advantage, it's not okay, it's not right. And also, the full restoration of range of motion and strength, especially the pronation and supination, may not be finally obtained, because about 18% of the patients did not regain this, even with this technique. Also, we did a comparative study between button and anchors in our clinic. We had 46 patients, males, with an acute tear less than 1 week, with a mean age of 41 years old. And 90% of those patients were heavy workers or athletes. So there are 2 groups, the groups of button repair without a cast, and the group of cast immobilization with anchors, about 3 to 4 weeks. And the methods of fixation were bone anchor with 4 surgeons, button fixation, me, 1 surgeon, and the clinical evaluation with these scores, and the radiological evaluation 1 year. And the mean follow-up was more than 1 year. So you can see this here, the results are similar, as you can see here, between group A and B. The pin palsy was only in group B1, and wrong placement of anchors or buttons in these cases, and the complications similar also. Now, this is an old review, about a systematic review of clinical studies, 40 articles with more than 1,000 patients, 4 fixation groups. There was no difference in range of motion and strength, and the complications were less common after the double incision approach with bone tunnel fixation, not with button or anchors. Also, in this systematic review, there is no difference in clinical outcome with regard to subjective patient weighting, pain, range of motion, supination strength when compared with 2 incisions of the button and the associated suture fixation techniques. And the last one is this from 2019, comparative clinical and functional assessment of cortical button versus suture anchor. And the comparison between the 2 study groups revealed no statistical significant difference in range of motion, VAS score, MEPI or quick dash. And the comprehensive comparison of 3 years outcome of cortical button versus suture anchor did not favor one fixation method over 2 others. So it's in the preference of the surgeon to use one or the other technique. So the take-home messages for this presentation is that clinical studies on cortical button are few, based on retrospective study designs. Good result in general with both techniques, but severe complications can be avoided with attention to appropriate surgical technique. And also patients have to be informed that they have range of motion and strength deficits, especially in pronation and supination, about 18%. This also there is a significant risk for tracing sensory nevropraxias. So button fixation is a more demanding operation, has higher incidence of nerve complications, and does not lead to faster recovery or better final range of motion and endurance. Thank you very much.